So this is going to be the psychopharmacology for our mood disorders. So we're going to be covering antidepressants and mood stabilizers. This information is in chapter 2 in your book. So we're going to start off with antidepressants. And as we discussed in part 1 of this lecture, we have a few different types of antidepressants. We have our SSRIs, our tricyclics, our MAOIs, and then our atypicals. So what do we use antidepressants for? We use antidepressants for major depressive illness, anxiety disorders. We can use them in the depressive phase of bipolar disorder. And then we can also use them for some of our psychotic disorders, especially if your patient's schizophrenic with depression, which would then be schizoaffective disorder. So, when we talk about the neurotransmitters that our antidepressants hit, we have a few different ones. So, our monoamine neurotransmitters, first one is serotonin. Serotonin is noted to keep us happy, calm, and it helps us with sleep. Norepinephrine provides us with energy, motivation, and focus. Dopamine is noted to be our motivation and our pleasure neurotransmitter. Acetylcholine is for our rest and digest, and then histamine is for our alertness. So, antidepressant mechanisms, right? The precise mechanisms of how they work is really not 100% known, but is noted in prior slide, we know their actions on our central nervous system. And we note that, we have serotonin, norepinephrine, dopamine, acetylcholine, and histamine. So antidepressant mechanism action, not fully known. It affects our central nervous system. We have our neurotransmitter interaction, norepinephrine and serotonin both play a key role in regulating mood, attention, arousal, sensory processing, and appetite. These neurotransmitters are released into the synapse and then reabsorbed by the presynaptic neurons. So, when we're taking medications that block them, it allows them to stay in that synapses longer. Um, Antidepressant action. So SSRIs block serotonin reuptake. Cyclic antidepressants block norepinephrine reuptake primarily, and serotonin to a lesser degree. MAOIs inhibit the enzymes of all of them, preventing neurotransmitter breakdown. And then delayed therapeutic effects. So the reuptake blockade of the MAOI inhibition occurs quickly, but really our therapeutic effects can take long. So when you're looking at questions, and you have a client who's on an SSRI and it's only been a few days, we note that it takes weeks for these medications to occur. Your cyclic compounds take 4 to 6 weeks. MAOIs, your book says 2 to 4 weeks. SSRIs, 2 to 3 weeks. And some literature says longer on that stuff. So again, we have our overview of our 4 groups. So when we're looking at our tricyclic antidepressants, also known as TCAs, these are older antidepressants that inhibit the serotonin and the norepinephrine. And they can also affect histamine and anticholinergic transmitters. They can block alpha 1 adrenergic receptors that can lead to orthostatic hypertension. Drawback, if we have, for the most part, clients, providers prefer SSRIs over tricyclics just because SSRIs have fewer side effects. Our SSRIs block serotonin, which is considered the primary mechanism for treating depression. It keeps serotonin, that synaptic cleft, longer, allowing our body to use it more. After a few weeks, the receptors, though, can become desensitized, which is kind of when that full effects is achieved. Our monoamine MAOIs, monoamine oxidase inhibitors, these act on all monoamine transmitters, so all of those ones that we just talked about on the slide beforehand. We have to use a lot of caution with MAOIs because they can create some pretty significant adverse reactions if the client has triamines with them, which we'll talk about in a few more slides. We also have SNRIs, and these are those atypical ones. It's similar to an SSRI, but it also increases norepinephrine, which kind of gives your client a little bit of increased energy level, but also having a calming effect. Clients can withdraw from these medications, especially if it's affecting their serotonin. They're going to have kind of like flu-like symptoms, some irritability, and some unusual sensations. Some clients will say like they get brain zaps. So we need to make sure that we taper off these medications to minimize withdrawal. And then we also have norepinephrine dopamine reuptake inhibitors. Those are also our atypicals. Those are stimulating antidepressants that act on norepinephrine and dopamine. They're not considered a controlled substance. Um, because the dopamine stimulation does not occur in the reward center of the brain. Usually, if something's affecting dopamine, it kind of gets into that controlled. But again, being that these do not affect that stimulation area for that reward, they're not controlled. This is just a table. You can find this in table 2.5 of your book that just gives the names of the SSRIs and the cyclets and the MAOIs and the other compounds. So when we talk about our side effects of SSRIs, commonly clients will have a little anxiety, a little agitation, especially when they're first starting them. Those sometimes go away. Sometimes they'll have some abdominal discomfort. Serotonin also gets produced in our stomach. Um, so the nausea goes away. Things like sexual dysfunction and weight gain, those side effects you really don't get used to. They don't go away. Those are a common reason why our clients stop taking their medications and are not compliant with their medications. Um, we need to make sure that a client is aware of how it affects them before they start, driving and doing things like that on them. Some of the medications could have a sedating value to them. They might have to be switched if it's too sedated for them. Our ciclets. So ciclets are contraindicated for clients that have severe liver impairment, or if your client recently had a cardiac event like an MI, it can increase their QT intervals. So we need to be cautious of other drugs like Zofran that can increase QT interval. They're going to give our clients some anticholinergic effects. So a refresher, if you're not sure what anticholinergic effects, this is when your patient's drying up. So if they're dried up, they're going to have dried mouth, they're going to have constipation, they're going to have urinary retention or hesitancy, and they could also have some blurred vision. More severe anticholinergic effects, agitation, delirium, and they can even get an ileus, which is that intestinal blockage. It's very common in our older adults. We can also have that orthostatic hypotension due to the cholinergic effects. And then your clients can have further issues with sedation, weight gain, tachycardia, sexual dysfunction, which the weight gain, the sexual dysfunction are common reasons why clients stop taking these medications as well. MAOI. So MAOIs, hypertensive crisis with triamine foods. That's probably one of the most tested questions because of these hypertensive crises can be life-threatening. So our basic side effects, these can have daytime sedation, some insomnia, some dry mouth, some orthostatic hypotension. Again, the hypertensive crisis, potentially life-threatening if the client ingests foods containing triamines. And I have those foods on the next slide for you, is considered a medical emergency. We also have potential fatal interactions if we prescribe an MAOI with an SSRI. And then here's our list of foods. So if your patient is on an MAOI and you see a question that, they're on the MAOI and they had cheese and now they're having headaches and hypertension, right? That's a medical emergency. They need to go to the emergency room and be treated. We can also have serotonin syndrome, especially if we're taking an MIOI with the SSRI. That's going to give your patient agitation, sweating, fever, tachycardia, hypotension, rigidity, hyperreflexia. In some cases, they can have coma and death. It's important that prior to starting a client on an SSRI that they've had enough time to get the MAOI out of their system. 5 half-lives, it'll be out, and then they can start on their new medication. Other side effects from our atypical antidepressants. So things like trazodone and mirtazapine can give us sedation, headaches, dry mouth, nausea. If we're taking like Wellbutrin, which is bupropion, we can have some loss of appetite, nausea, insomnia. Bupropion's kind of got that dopamine norepinephrine thing going on. If they're on venlafaxine, they can have dizziness, sweating, and sedation. Um, Trazodone is known for the potential for priapism. So it's really important if you have a male patient that they know that trazodone can give them priapism. Education for our clients and antidepressants. So with SSRIs, usually we say to take it first thing in the morning unless sedation is a concern. If they miss a dose, they can take it up to 8 hours after the missed dose. With our cyclic compounds, usually these are taken at night. It's usually a single dose if possible. And then if they have a missed dose, they can take it within 3 days of the missed dose, or they can omit for the day, your book says. Driving, alert activities, we need to be cautious. As I said before, some of these medications can reduce our reflexes and cause us to have sedation. So it's better for them to be aware of kind of how their body's going to act on it before they start going out and doing, driving and activities. MAOIs, right? Number one, dietary restrictions. Do not forget about your triamine foods, right? Those aged cheeses, beers, wines, and things like that. Um, they also need to be aware of any other medications they're on that could affect that. Mood stabilizers and anticonvulsants, right? So the only true mood stabilizer is lithium. Lithium is considered the golden standard of caring for clients with bipolar. However, in practice, you're going to see it's not often prescribed, and that has to do with its everything that the client needs to do to be on it. And we'll go over all of that. It's a lot of monitoring. And then we have our anticonvulsants, which is our anti-seizure medications. Topamax and gabapentin are usually not considered primary treatment for bipolar, but they can be used adjunctively. So, mechanism action. Lithium normalizes the reuptake of the neurotransmitters. Valproic acid and topamate increase levels of GABA. Valproic acid and carbazepine inhibit the kindling process. And kindling I talked about in one of the earlier lectures, but in mental health, kindling refers to the phenomenon where repeated episodes of mental illness like depression or bipolar can lead to increasingly severe symptoms over time, making future episodes more likely to occur and potentially more intense, even with seemingly small triggers. Essentially, each episode kindles the brain further, making it more susceptible to future episodes. Similar to how repeatedly adding small pieces of kindling cause the fire to build up in flames. So our side effects, lithium. Ooh, lithium has a battery of side effects. And some of them, get better as the patient's been on them longer. They get more tolerable to them. Um, let's see, what else do I have here? Carbazamine and valproic acid are going to have drowsiness, sedation, dried mouth, and blurred vision. It is usually good to know the difference between expected side effects and then toxicity of lithium. So, again, lithium has a very therapeutic range. Your book talks about maintenance level of zero point 0.5 to 1, treatment level zero point 0.8 to 1.5, toxic levels anything greater than 1.5. If your client has 1.5 to 2, we're going to see nausea, vomiting, diarrhea, reduced coordination, drowsiness, slurred speech, muscle weakness. If they get from a 2 to a 3, they're going to have ataxia, agitation, blurred vision, tetanies, the ringing of the ears, um, confusion, hyperreflexibility, incontinence of their bowel and bladder, slurred speech, and vertigo. If it's greater than 3, we're going to start to see cardiac arrhythmias, hypotension, peripheral vascular collapse, seizures, stupor, coma, death. So, these are the side effects of the other anticonvulsants. So carbazepine, we can have a rash. It can be a life-threatening rash. Steven Johnson's orthostatic hypotension. Valproic acid, we're going to see weight gain. They could have alopecia. They can have a hand tremor. And then Topamax, we're going to have dizziness, sedation, and weight gain. Client education with lithium, again, pretty common test subject information. So we need to make sure that the client stays well hydrated. They need to drink about 2 liters a day. They do not need to increase their salt intake. Lithium has salt with it. They need let's see, monitors of their weight. They need to be checking for edema, and they need to contact their physician if they're experiencing anything like diarrhea, fever, flu, dehydration, because if they become depleted on their water, they're going to have potential toxic lithium levels. So somebody could be maintained on their lithium level for years, get a really bad GI bug, and then end up becoming toxic. So we just need to be mindful of that. Thyroid function, baseline prior to starting it, and then every 6 months, we can have increase of our TSH levels that can cause anxiety, lability, and sleep issues, and then decreased TSH levels is going to be linked to fatigue and depression. Lithium can affect the client's thyroid, so we need that baseline to make sure that they're not having hyperthyroid going on. And then we need to monitor it to make sure that the lithium's not hurting the thyroid and therefore creating maybe a worsening of depression, but it's really because of the medication. And then renal function, right? Regular renal assessments is really important for clients on lithium. It's primarily excreted through the urine. Older adults may require lower doses due to their already reduced renal function, and it is contraindicated in those with comprised renal function if they're having urinary retention, low salt diets, diuretics, or brain cardiovascular damage. Teaching for the others, we want to make sure that if the client's taking lithium and an anticonvulsant, that we monitor the blood levels periodically for the other anticonvulsant as well as the lithium. We want to make sure that the last time the dose, so if they take the medication, we need to check it 12 hours after the last dose. Um, Taking the medications with meal minimizes nausea. And again, the client shouldn't drive until they know how they feel on it. These medications can cause dizziness, lethargy, fatigue, and blurred vision. Lab work, this is just going over the lithium level again. So 0.5, 0.6 to 1 is maintenance level. I've seen literature that goes up much higher than that, but we're sticking to what your book says. Depakote, they should monitor. Depakote can also cause liver damage and low platelets. So, as well as the Depakote level, we might need to do some chemistries and some CBCs. Lamictal does not require any labs. Tegretol um, does not have a level for mental health. With Tegretol, we have to be concerned about anemia, neutropenia, sodium, and liver. And triliptal also does not have a level. This slide I created just as an overview of lithium because if it is such a highly testable content, that way everything's kind of in one area for lithium. And that is the end of this lecture.